Hello, my name is Chantel Manhart. We're going to cover Chapter 5, Fluids and Electrolytes, Acids and Bases, for Nursing 308 for Northern Illinois University. So, we're going to talk about the distribution of body fluids. The human body requires a delicate balance of homeostasis to function optimally. The body continuously employs strategies to maintain this balance. Fluid, electrolytes, and pH all play critical roles in sustaining homeostasis. Body fluid is made up of water and solutes. Water is the medium within which metabolic reactions and other processes occur. Water carries nutrients into the cells, waste products out of the cells, enzymes in digestive secretions, and blood cells around the body. Fluid also facilitates movements of body parts. Fluid found inside the cells is referred to as intracellular fluid, and fluid found and fluid found outside the cells is referred to as extracellular fluid. Extracellular fluid is further divided into interstitial, which means between the cells, and intravascular, which is inside the blood vessel compartments. So we've got the two types of fluid, interstitial and intravascular. The cell membrane serves as a barrier that substances and water must pass through to move into or from the intracellular compartment. A third compartment, which fluid is found in, is the transcellular compartment, which includes the following types of fluid: peritoneal, pleural, pericardial cavities, your cerebrospinal fluid, and your fluid in your joint spaces, your lymph system, your eyes, and your fluid in your gastrointestinal tract. Transcellular fluid makes up about 1% of the body fluids. The intracellular fluid accounts for approximately 2/3 of the body's water and is rich in potassium, magnesium, phosphates, and proteins. 1/3 of the body fluid is the extracellular fluid, and of that, 80% is from the interstitial compartment, and 20% is the intravascular compartment. The extracellular fluid is rich in sodium, chloride, and bicarbonate. So when we draw blood in our serum and electrolytes, we're only looking at the intravascular compartment. This is just a pictorial of that. So we're going to talk about electrolyte balance. Electrolytes play a crucial role in homeostasis. Electrolytes are minerals with electrical charges found in blood, urine, and other body fluids. Electrolytes in the body include sodium, chloride, potassium, calcium, magnesium, and phosphorus. Electrolytes are substances that are known as ions. There's cations are positively charged, or there's ions which are negatively charged. Non-electrolytes are particles that do not dissociate into charged particles, such as urea or glucose. So if we're talking about water movement between the fluid compartments, the transfer of the water takes place at the capillary level between the vascular and the interstitial compartments. There's four main forces to control movement. There's forces favoring filtration. So then when we're looking at that, we're looking at the capillary hydrostatic pressure or blood pressure, which facilitates the outward movement of the water from the capillary into the interstitial space. We have the interstitial iconic pressure, which is where pulling the osmotically attracts water from the interstitial space back into the capillary. And then we have the forces favoring reabsorption. So we have plasma, which is the capillary onconic pressure, water pulling, which facilitates the inward movement of water from the interstitial space into the capillary. Or we have the interstitial hydrostatic pressure that osmotically attracts water from the capillary into the interstitial space. Tonicity is the osmotic pressure of the two solutions separated by a semipermeable membrane. This characteristic is often used to describe the cell's response to the external solution. Much like osmotic pressure, tonicity is influenced by the solutes that cannot cross the membrane. In healthcare, the external solution described in relationship to tonicity consists of intravenous solutions, specifically those containing electrolytes. So, for instance, crystalloids that are used to treat a variety of patient conditions would be a good example of this. This just shows fluid movement between the plasma and interstitial space. So as we're talking about edema, edema is defined as palpable swelling produced by an expansion of the interstitial fluid volume. Edema does not become evident until the interstitial volume has been increased by 2.4 to 3 liters. Causes can be increase in capillary hydrostatic pressure. This increases as a result of venous obstruction or salt and water retention. Examples are congestive heart failure, renal failure, and cirrhosis of the liver are associated with excessive salt and water retention. We have decrease in plasma onconic pressure. This happens when the plasma albumin acts like a magnet to attract water. The loss or the diminished production contributes to decreased plasma onconic pressure. Examples of this are glomerular disease of the kidneys, serous drainage from open wounds, hemorrhage, burns, and cirrhosis of the liver. We can have increase in capillary permeability, which is capillaries become more permeable with the inflammation and immune responses, especially with trauma such as burns or crushing injuries, neoplastic disease, and allergic reactions. Proteins escape from the vascular space and produce edema through decreased capillary onconic pressure and interstitial fluid protein accumulation. Lymph obstruction, such as lymphedema, when lymphatic channels are blocked or surgically removed, proteins and fluids accumulate in the interstitial space, causing lymphedema. This usually follows the removal of axillary or femoral lymph nodes for cancer treatment. You can have localized or general edema. So it could be localized to one area, such as the feet, or it could be generalized throughout the body, which we call an asarcia, I think is how we pronounce it, Ansarca, and that's ANASARCA. Hypervolemia is an excess fluid in the intravascular compartment. This may be due to the excess sodium or water intake or insufficient losses. Clinical manifestations of fluid excess could be peripheral edema, dyspnea, bounding pulse, tachycardia, jugular vein distension, hypertension, polyuria, rapid weight gain, crackles, bulging fontanelles like in infants. Main diagnostic procedures for fluid excess um, is urine and blood specific gravity. Osmolality will be decreased due to solute dilution. Blood count, blood cells, RBCs, and platelets may be decreased because of the high ratio of fluid. This is a great picture to show you pitting edema. You can see where somebody has put their fingers into this um, person's foot and it just has stayed. Um, so this is a great example of pitting edema. So edema manifestations. Manifestations are determined by its location. Obviously, brain, larynx, or lungs is acute and life-threatening. Joint, it's going to interfere with movement, obviously. Edematous tissue causes injury or can development of ischemic tissue damage, including pressure ulcers. Pitting edema occurs when there's the accumulation of the interstitial fluid exceeds the absorption capacity of the tissue. Brawny edema is the type of non-pitting edema in which the skin thickens and hardens, and it gets that kind of brownish look. Non-pitting edema is most frequently seen after local infection or trauma. This is just showing you how edema can go to the different spaces. So we're going to have edema assessment and intervention. Assessment of edema includes daily weight at the same time each day with the same amount of clothing provides a useful index of water gain. So 1 liter of water weighs 2.2 pounds due to edema. Your visual assessment is a measurement of the affected part. So you visually inspect and measure, and measurement of circumference of an extremity can also be useful to assess the degree of swelling. This is particularly useful when swelling is due to like thrombophlebitis. An application of finger pressure to assess for pain edema. If an indentation remains after the finger has been removed, pitting edema is identified. It is an evaluation on a scale of 1 minimal to 4 plus being severe. The earlier picture we showed would have been a 4 plus. Management is aimed to correct and control, cause, and prevent tissue injury with edema. The treatment of edema usually is directed towards maintaining life when the swelling involves vital structures, correcting or controlling the cause, and preventing tissue injury. So we start simple. We can elevate the feet to reduce edema in the lower extremities. We can use elastic support stockings and sleeves to, increase interstitial fluid pressures and resilience to outward movement of the fluid from the capillaries into the tissue spaces. These are used with patients that have lymphatic or venous obstruction and are applied in the morning before the effects of gravity have caused the fluid to move into, like for instance, the ankles. We'll use these a lot with our mastectomy patients if they're going to fly. Also, to prevent that lymphedema in their arms. Serum albumin levels. Serum albumin levels can be measured, as can the colloidal osmotic pressure of the plasma. Albumin can be measured intravenously to raise the plasma colloidal osmotic pressure when edema is caused by hypoalbuminemia. So that's one reason we'll be doing that. We also have diuretics, which are commonly used to treat edema, such as Lasix, spirulactone, Bumex. Range of motion is also used to help reduce the stasis and accumulation of fluid. Patients don't always realize if they move, it helps. If you see somebody who sits all day, they're going to get that where their ankles swell. And we've got to remember, we want skin care. We want meticulous skin care to help prevent the skin breakdown, because when they get that edematous tissue, it's just asking to develop skin breakdown and pressure ulcers, especially if they're laying in a bed with this full body edema. Okay, I'm going to reiterate on edema for a second. I have seen also where PT has used kinesio tape, which I think you've probably all seen that. But they will cut it in strips and use it on the extremities to help pull that fluid up and out. And it works pretty well. It's very interesting how well it does work. Okay, we're going to now talk about third spacing. Third spacing represents the loss or trapping of extracellular fluid into the transcellular space. It's located in strategic body areas where there is continued movement of body structures. Pericardial sac is pericarditis or pericardial effusion. Peritoneal cavity is ascites. Your pleural cavity is a hydrothorax. The exchange of extracellular fluid between the capillaries, the interstitial spaces, and the transcellular space of the serous cavity uses the same mechanisms as capillaries elsewhere in the body. The serous cavities are closely linked with the lymph drainage systems. The milking action of the moving structures, such as the lungs, continuously forces fluid and plasma proteins back into the circulation, helping keep these cavities empty. Any obstruction to the lymph flow causes fluid accumulation in the serous cavities. As with edema, third space fluids represent an accumulation or trapping of body fluids that contribute to body weight but not to fluid reserve or function. This can be fatal if it's not corrected. So we're going to talk sodium and chloride balance. Sodium is considered the most significant cation, the most prevalent electrolyte within the extracellular fluid. Sodium's primary function is to control serum osmolality and water balance. Sodium is important in other functions, including maintenance of neuromuscular irritability, for conduction of nerve impulses, regulation of acid balance, base balance, participation in cellular chemical reactions, and transportation of substances across the cellular membrane. Sodium has an affinity for chloride and helps maintain acid-base balance when combined with bicarbonate. Aldosterone is produced by the adrenal cortex. In times of high serum osmolality or low blood volume, aldosterone is released, and the kidney volume. Aldosterone is released and the kidneys retain sodium then. And the opposite is true when serum osmolality decreases and fluid volume increases. The sympathetic nervous system assists the kidneys in sodium regulation by changing the glomerular filtration rate, which is a reflection of the renal blood flow. Increasing the glomerular filtration rate increases sodium excretion. Decreasing the glomerular filtration rate decreases sodium excretion. So the renin-angiotensin sodium excretion. So the renin-angiotensin aldosterone mechanism also manipulates sodium in the kidneys. So this mechanism is triggered in times of decreased renal perfusion. So renin, a protein, converts angiotensin to angiotensin 1. Subsequently, angiotensin 1 is converted to angiotensin 2 in the lungs. Angiotensin 2 causes the kidney to retain sodium and, in turn, water. The cellular membrane is permeable to sodium, but it is dependent on the sodium-potassium pump to transport these ions. Sodium facilitates muscle and nerve impulses through the pump. As sodium moves into the cells, potassium shifts out of the cells, resulting in depolarization of the cell membrane. When sodium shifts out of the cells, potassium moves back into the cells, resulting in repolarization of the cell membrane. Normally, sodium losses occurs in the kidneys. Excessive losses can occur throughout the gastrointestinal tract through vomiting, diarrhea, and nasogastric suctioning also. So, your renin-angiotensin aldosterone system, your R, otherwise known as RAAS, is a hormone system that regulates the blood pressure and fluid balance. Renin is a small protein enzyme, like I said, that is released by the kidney in response to changes in arterial pressure, the glomerular filtration rate, and the amount of sodium in the tubular fluid. Renin itself has no direct effect on blood pressure, but when it is released, it is an enzymatic property convert circulating plasma protein called angiotensin to angiotensin 1. When angiotensin 1 leaves the kidney and enters circulation, it enters the lungs and reaches angiotensin converting enzyme, which catalyzes its conversion to angiotensin 2. Angiotensin 2 is a potent vasoconstrictor and acts directly on the kidney to decrease salt and water excretion. It has a short period of action. Angiotensin 2 also stimulates the secretion of aldosterone by the adrenal gland, excreting a more long-term effect on maintenance of blood pressure. I figured that way you also have it written down where you can see it, and we reiterated it twice because I know that gets confusing when you're looking at it. So water balance in ADH. ADH secretions controlled by the ECF volume and osmolarity. The reabsorption of water by the kidneys is regulated by ADH. Vasopressin. ADH exerts its effect through two types of vasopressin, receptor V1 and V2 receptors. The V2 receptors, located on the tubular cells of the cortical collecting duct, control water absorption by the kidneys. Binding of the ADH to the V2 receptors increases water absorption by increasing the permeability of the collecting duct to water. Osmoreceptors in the hypothalamus sense changes in the extracellular osmolality and stimulate the production and release of ADH. A small increase in serum osmolality of 1% is sufficient to cause ADH release. Stretch receptors that are sensitive to change in BP and the effective circulating volume also contribute to the regulation of ADH release. A blood volume of 5 to 10% produces a maximal increase in ADH levels. So when we're talking about disorders of ADH, we're talking diabetes insipidus or syndrome of inappropriate antidiuretic hormone. And we'll talk about those. This is just a pictorial of the ADH system. So, diabetes insipidus is caused by a deficiency or a decreased response to ADH, inability to concentrate urine during periods of water restriction. They have large volumes of urine daily. Sorry about the phone, guys. Anywhere from 3 to 20 liters per day. They have polydipsia or excessive thirst. There's two different types. There's central or neurogenic diabetes insipidus, which is the inability to synthesize ADH. There's nephrogenic diabetes insipidus, which is the inability to respond to ADH. So there are those two different types. Manifestations of diabetes insipidus include intense thirst. They crave ice water and polyuria. They can have hypernatremia and dehydration. The preferred drug for treatment is for chronic diabetes insipidus is desmopressin acetate or DDAVP. And one thing is these patients should not be limited on their water intake. They all should have be wearing medical alert bracelets so that we know who these patients are. Because if we do restrict their fluids, it could be fatal to them. So, syndrome of inappropriate antidiuretic hormone results from a failure of the negative feedback system that regulates release and inhibition of ADH. ADH continues even when serum osmolarity is decreased. Its causes are marked by retention of water and excess sodium and dilutional hyponatremia, an increase in the glomerular filtration rate resulting in an increased plasma volume causes further increase in sodium loss by suppressing the renin angiotensin mechanism. It can be a transient condition as in a stress situation or as a chronic condition resulting from disorders such as lung tumors, manifestations of SIADI can be delusional hyponatremia, decrease urine output even though urine osmolality is high and serum osmolality is low, increase or adequate fluid intake, a decrease in hematocrit, sodium, and BUN due to expansion of the extracellular fluid volume. Treatment in mild cases consists of fluid restriction. If fluid restriction is not sufficient, diuretics such as mannitol, furosemide may be given to promote diuresis and free water clearance. Lithium and demeclacillin inhibit the action of ADH on the renal collecting ducts and sometimes are used in treating this disorder. So water balance, we're going to talk about thirst thirst mechanism is located in the hypothalamus. It's the level of the antidiuretic hormone ADH presents in the body along with thirst to work to regulate water balance in the body. The thirst perception is a common symptom of fluid deficit. Osmolality receptor develops as the effective circulating volume decreases to a point sufficient to stimulate the thirst mechanism. Urine output decreases and urine osmolality and specific gravity increases as ADH levels rise because of a decrease in vascular volume. So then our volume receptor, although there is an isotonic loss of fluid from the vascular compartment, blood components such as red blood cells and urea become more concentrated. Our baroreceptors, arterial and venous volumes decline during periods of fluid deficit, as does filling the capillary circulation. As the volume in the arterial system declines, the blood pressure decreases, heart rate increases, and the pulse becomes weak and thready. Postural hypotension is an early sign of fluid deficit, characterized by the blood pressure that is at least 10 millimeters lower than the patient is sitting or standing when the patient is lying down. Disorders of thirst can include hypodipsia or polydipsia. So isotonic alterations are total body water change with the proportional electrolyte water change, or no change in concentration. Isotonic fluid loss is caused by a decreased fluid volume. So we can see a decrease in body weight. Signs of compensatory mechanisms could be rapid, weak, thready pulse, low blood pressure, or orthostatic hypotension. We can see a decrease in the interstitial fluid volume, decreased skin turgor, dry mucous membranes, decreased vascular volume. We can have an increased hematocrit, increased electrolytes. Urine could be high specific gravity, low volume, isotonic fluid excess. It occurs secondary to an increase in total body sodium, which in turn leads to an increase in body water. We can have an increase in weight, increase in interstitial fluid volume, localized swelling in the hands, feet, periorbital areas, ascites. They could have pale, gray, or red skin color. We can have an increase in vascular volume, which is slow bounding pulse, high blood pressure, pulmonary congestion. We can have a decrease in hematocrit, decreased serum sodium, urine, and loss of specific gravity with high volume. So, isotonic alterations, total body water change with proportional electrolyte and water change. Isotonic fluid loss is caused by a decreased fluid volume, decrease in body weight, sign of compensatory mechanisms, decrease interstitial fluid volume, decrease vascular volume. These are hard to measure and as actual gains or losses. Isotonic fluid excess, it occurs secondary to the increase in the total body sodium, which in turn leads to an increase in body water. So we can see an increase in weight, increase in interstitial fluid volume, increase in vascular volume. Although the fluid volume excess can occur as a result of the increased sodium intake, it is most commonly caused by a decrease in sodium and water elimination by the kidney. So we're talking about hypertonic alterations, hypernatremia, serum sodium greater than 145 milliequivalents per liter, related to sodium gain or water loss, water movement from the ICF to the ECF. Intracellular dehydration, where is controlled by the kidneys through the action of aldosterone. Manifestations, most life-threatening cerebral edema, increased intracranial pressure, lethargy, confusion, decreased reflexes, seizures, and coma. It leads to loss of ECF and hypovolemia. You will see hypotension, tachycardia, decreased urine output. If delusional from excess water, you'll have hypervolemia, hyponatremia. You'll see weight gain, edema, ascites, jugular vein distension. It's managed. Management focuses on treating the underlying cause, and you're going to do diagnostic procedures for hyponatremia are similar to those for hypernatremia. We are going to administer corticosteroids for Addison's. Deficient sodium oral intake may be increased slowly as not to overload the heart. Additional seizure precautions, and we're going to have low lighting and decreased stimuli and do neurochecks for this. So when we're talking water deficit, obviously that's dehydration. Pure water deficit is occurring when water losses are equal to 0.5% of body water. Urine output is decreased and urine osmolality is increased. Renal free water clearance. So manifestations, you can have hypovolemia, tachycardia, weak pulses, and postural hypotension. You're going to have a marked water deficit. You're going to have headache, thirst, dry skin, mucous membranes, fever, weight loss, concentrated urine. You will see an elevated hematocrit and serum sodium level. So when we're still talking about these hypotonic alterations, you can have decreased osmolality below 280. You can have hyponatremia or free water excess. Fluid contains fewer solutes than blood. You can have hyponatremia, decreases the ECF, osmotic pressure, and the water moves into the cells via osmosis. The cell expands and swells. An example of this is when we're using 0.45% normal saline. So that gives you an example of that. Okay, now we're going to get down into some of the specific things. Hyponatremia is serum sodium level below 135 milliequivalents per liter. Sodium losses cause a hypoosmolality and tissue swelling. Causes can be obviously direct sodium loss, low intake, delusional hyponatremia, hypoosmolar hyponatremia, hypertonic hyponatremia. Manifestations could be muscle cramps, weakness, headaches, depression, apprehension, lethargy, stupor, coma. If hypovolemia, they're going to be tachycardic. If tachycardia, hypotension, decreased urine output. This is due to the loss of this ECF and hypovolemia. Delusional hyponatremia is from excess water. They're going to have weight gain, edema, ascites, jugular vein distension. This is seen with edema forming disorders such as CHF, cirrhosis, and advanced kidney disease. So, potassium. It's a major intracellular cation and the second most abundant cation in the body. But approximately 2% of the body potassium is contained within body cells with an intracellular concentration of 150 to 160 milliequivalents. Concentration is maintained by sodium and potassium pump. The sodium-potassium pump maintains the balance of the potassium between the ECF and the ICF by active transport. It regulates intracellular electrical neutrality in relation to sodium and hydrogen. It is required for glycogen and glucose deposition in the liver and skeletal muscles. It also maintains the resting membrane potential as it reflected in the transmission and conduction of nerve impulses, the maintenance of normal cardiac rhythms, and the contraction of skeletal muscles and smooth muscles. So potassium levels should be 3.5 to 5.0 milliequivalents per liter. Changes in pH affect potassium balance, and thus in hydrogen ion concentration also affect potassium balance. During acute acidosis, hydrogen ions accumulate in the ICF. During states of acidosis, potassium shifts out to maintain a balance of cations across the membrane, resulting in hyperkalemia. Aldosterone not only conserves sodium but regulates potassium concentration. Elevated plasma potassium concentration causes the release of renin and the adrenal secretion of aldosterone through the renin. Angiotensin-aldosterone system. Aldosterone then stimulates the release of potassium into the urine by the distal renal tubules. Aldosterone also increases the secretion aldosterone also increases the secretion of potassium from sweat glands. Insulin helps regulate the plasma potassium levels by stimulating the sodium-potassium ATPase pump, thus promoting the movements of potassium into liver and muscle cells, particularly after eating. Insulin can be used to treat hyperkalemia. Dangerously low levels of plasma potassium can result when insulin is given while potassium levels are depressed. Epinephrine facilitates the movement of potassium into the muscle tissue. The action of epinephrine on potassium transport is additive to that of insulin. The kidney is the most effective regulator for patients with kidney failure having problems with potassium regulation. Potassium adaptation is the ability of the body to adapt to increased levels of potassium intake over time. A sudden increase in potassium may be fatal, but if the intake of potassium is slowly increased by amounts of no more than 120 milliequivalents per day, the kidney can increase its urinary excretion of potassium and maintain potassium balance. Slow changes tolerate better than acute. So hypokalemia is a potassium level less than 3.5 milliequivalents per liter. Because of transcellular shifts, temporary changes in serum potassium may occur as a result of movement between the intracellular and extracellular compartments. Potassium balance is described by changes in plasma potassium levels. Causes reduced intake of potassium. A person needs 10 to 20 milliequivalents a day to compensate for obligatory urine losses. Increased entry of potassium into cells. This can happen when insulin is given. Glucose and potassium move into cells. Theophylline is another medication that can move potassium, and increased loss of potassium from the body stores are usually caused by gastrointestinal, renal disorders, diarrhea, intestinal drainage tubes or fistula, and laxative abuse also results in hypokalemia. Normally, you will lose 5 to 10 milliequivalents of potassium, and up to 10 to 150 mLs of water are excreted in stool each day. With diarrhea, it can be several liters of 100 to 200 milliequivalents of potassium loss per day. Manifestations depend on the rate of severity. Membrane hyperpolarization causes a decrease in neuromuscular excitability, skeletal muscle weakness, smooth muscle atony, and cardiac dysrhythmias. So, hyperkalemia is a potassium level greater than 5.5 milliequivalents per liter. Hyperkalemia is rare because of the efficiency of the renal excretion. It can be caused by increased intake, or it can be a shift of potassium from the ICF to into the ECF. Decreased renal excretion, which is due to usually renal failure, adrenal insufficiency would be another cause. Treatment is usually with potassium-sparing diuretics. It can be treatment with angiotensin, converting enzyme inhibitors, insulin deficiency. It's released from intracellular compartment as in tissue trauma, burns, crushing injuries, extreme exercise, or seizures. We've seen mild attacks can cause increased neuromuscular irritability, which is going to show as restlessness, intestinal cramping, and diarrhea. In severe attacks, you're going to see decreases the resting membrane potential, and you're going to have muscle weakness, loss of muscle tone, and paralysis. Cardiac dysrhythmia, sinus bradycardia, atrioventricular block, proximal atrial tachycardia. Hypokalemia increases the risk of digitalis toxicity. You might see echocardiogram changes such as a flat T wave is a hallmark sign, ST segment depression, and an appearance of a U wave. Severe hypokalemia will see peaked P waves and lengthening of the QT interval. This is just showing you some of those EKG changes. Calcium is 9 to 10.5. 99% of the calcium is located in the bone, the remainder in the plasma and body cells, with 50% bound to plasma proteins, 40% free or ionized. Ionized form is the most important physiologically. Um, it is needed for, calcium is needed for fundamental metabolic processes. It's the major canton for structure of bones and teeth, enzymatic cofactor for blood clotting, required for hormone secretion, cell receptor function, directly related to the plasma membrane stability, transmission of nerve impulses, muscle contraction, parathyroid hormone, vitamin D3, and calcitonin act together to control calcium absorption and excretion. It is excreted in the urine, feces, and bone. You may see serum concentrations as low as 8.8 to 10.5. Hypocalcemia is serum calcium levels less than 9 milliequivalents per liter. Causes calcium must bind to albumin, and a decrease in albumin in the body results in a decrease in calcium levels. So, inadequate intestinal absorption of calcium or vitamin D, the deposition of ionized calcium into bone or soft tissue, blood administration, the decrease of PTH, hypoparathyroidism, alkalosis from increased blood pH, renal failure. Nutritional deficiencies occur with inadequate source of dairy products or green leafy vegetables. The effects can be increased neuromuscular excitability. Terse sign with a blood pressure cuff is inflated on the arm. You will get a carpopedal spasm or contraction occurs in the hand and the fingers. Chevesque sign is tapping of the facial nerve in the front of the ear, results in a spasm of the lips and the face. Tingling muscle spasms, particularly in the hands, feet, and facial muscles. Intense intestinal cramping, hyperactive bowel sounds. Severe cases show convulsions and tetany. Prolonged QT interval and cardiac arrest have all been related to this. Hypercalcemia is serum calcium levels greater than 10.5 milligrams per deciliter. Causes can be hyperparathyroidism, bone metastasis with calcium reabsorption from breast, prostate, renal, and cervical cancer, sarcoidosis, excessive vitamin D intake. Many tumors produce the PTH, parathyroid hormone, hyperparathyroidism, prolonged immobility causing demineralization of the bone, increased intake of dietary calcium, excessive intake of milk and antacids can cause this. Effects can be many nonspecific: fatigue, weakness, lethargy, anorexia, nausea, constipation, impaired renal function, kidney stones. You can get dysrhythmias such as bradycardia, shortened QT segment, depressed T wave, heart block, cardiac arrest. You can even get bone pain and osteoporosis even with hypercalcemia. Magnesium, it's an intracellular canton. Serum concentrations are 1.8 to 3.0 milliequivalents. It's a major intracellular electrolyte second to potassium. It acts as a cofactor in the intracellular enzyme reactions. It increases neuromuscular excitability. Imbalances of magnesium are rare. The kidneys and small intestines are responsible for magnesium metabolism. Half of the body's magnesium is stored in bone. It's ingested with dietary intake of green leafy vegetables. Magnesium has been used for treatment of preeclampsia and pregnancy and also been found to be beneficial in the treatment of depression, migraine headaches, heart disease, and asthmatic respiratory conditions. So, hypomagnesemia, that's kind of hard to say, is levels less than 1.5 milliequivalents per liter. Low magnesium levels can cause potassium to move outside of the cells, causing malnutrition, malabsorption syndromes, alcoholism, urinary losses through the renal tubular dysfunction and loop diuretics, prolonged use of proton pump inhibitors, diabetes mellitus, widespread inflammation of the body, use of diuretics, and hyperparathyroidism. The effects are behavioral changes, irritability, increased reflexes, tremors, muscle cramps, ataxia, nystagmus, tetany, convulsions, tachycardia, hypotension, and cardiac arrhythmias, to name a few. So, hypermagnesiemia, total serum magnesium level greater than 3 milliequivalents per liter. This is rare. Causes are usually renal insufficiency or failure, excessive intake of magnesium containing antacids, or adrenal insufficiency. Effects can be skeletal smooth muscle contraction, diminished reflexes, lethargy, excessive nerve function, loss of deep tendon reflexes, nausea, vomiting, muscle weakness, hypotension, bradycardia, cardiac arrhythmias, and respiratory distress. So, when we're talking acid-base balance must be carefully regulated to maintain a normal pH via multiple mechanisms. Slight changes in the amounts of hydrogen and changes in pH can significantly alter the biological processes in cells and tissues. Hydrogen ion is needed to maintain the membrane integrity and speed of metabolic enzyme reactions. Normal pH is required for the membrane excitability, enzyme systems, and chemical reactions. Most pathological conditions disrupt acid-base balance, producing circumstances possibly more harmful than the disease process itself. An acid is a molecule that can dissociate and release a hydrogen ion. A base is an ion or molecule that can accept or combine with a hydrogen ion. So pH. When we're talking pH, the negative logarithm of the hydrogen concentration. So if the hydrogen ions are high in number, the pH is low, it's acidic. If the hydrogen ions are low in number, the pH is high, it's alkaline. Acids are formed as end products of protein, carbohydrates, and fat metabolism. To maintain the body's pH, which is 7.35 to 7.45, the hydrogen ion must be neutralized or excreted. Normal pH is required for cellular function, and there is a narrow pH range. When hydrogen ions exceed this concentration range, death may occur. Arterial blood gases are obtained to determine the pH level of the blood. Laboratory results can also be evaluated for a base excess or deficiency of an ion gap to determine acid-base balance. The bone, lungs, kidneys are the major organs involved in the regulation of acid-base balance. So, pH, volatile and non-volatile acids. So body acids exist in two forms. There's volatile, which is your H2CO3 that can be eliminated as CO2 gas, or there's the non-volatile, which can be eliminated by the kidney. That's sulfuric, phosphoric, and other organic acids. They are strong acids, readily released by their hydrogens. The hydrogens are secreted into the urine, so they're eliminated by the renal tubules with the regulation of the HCO3. So buffering systems. A buffer is a chemical that can bind excessive hydrogen or OH without a significant change in pH. The most important plasma buffering systems are the carbonic oxide bicarbonate pair. Buffers react with the acids and alkali in the blood to maintain a pH of 7.35 to 7.45. Buffering systems act immediately when there is a change in pH is recognized by the body, but are the weakest of the body's pH control systems. So there are four major buffering pairs. There's the sodium bicarbonate carbonic acid system, the major buffer of the ECF compartment, the main buffer system used to clinically diagnose a client's acid-base imbalance. The ratio of bicarbonate ion to carbonic acid must be 20:1 and maintain a pH balance. More bicarbonate is necessary to neutralize acid. Changes in the bicarbonate ion and carbonic acid must be equal to maintain the pH balance. It works in both lungs and kidneys. In the phosphate system, it attaches to the protein and phosphate. Intracellular buffer acts to defend the body's first against acid-base imbalance. Ammonia and phosphate attach to the hydrogen ions and acts as a buffer in the renal system. The hemoglobin system is intracellular blood buffer, able to bind with the hydrogen ions and the carbon dioxide. Hemoglobin weakens the acid. Protein system is negatively charged proteins in both ICF and the ECF work as hydrogen ion buffers. In the respiratory system, it controls the rate of the respirations in order to maintain the pH balance of blood. The chemoreceptors recognize changes in pH and PaCO2. Respirations increase when serum carbon dioxide levels increase in an attempt to rid the body of more acid in the form of carbon dioxide. The response to change in pH balance within minutes to hours. The renal system, kidneys provide the bicarbonate ion necessary to form buffer pairs. The renal system can reduce body acid by exchanging hydrogen ions for sodium and extracting acid through urination. Changes the pH of urine as needed to regulate blood pH. The most powerful body system to correct acid-base balance, but may take hours or days to work. The renal buffer ammonia does not carry an electrical charge, allowing it to cross the cell membrane in the kidneys, binding with hydrogen, and then being eliminated from the body with urination. Kidneys are able to reestablish bicarbonate in order to neutralize acid in the blood. Normal urine pH is 4.5 to 8. So the carbonic acid and bicarbonate pair operates in the lung and the kidneys and is the major extracellular buffer, like we talked about before. The lungs is the second line of defense and can relatively quickly, within seconds to minutes, decrease the amount of carbonic acid by blowing off carbon dioxide and leaving water. The kidneys are the third line of defense, hours to days, and can reabsorb carbonate, a type of base, or regenerate a new carbonate from carbon dioxide and water. The greater the partial pressure of carbon dioxide and the more carbonic acid is formed. At pH of 7.4, the ratio of carbonate to carbonic acid is 20:1. Carbonate and carbonic acid can increase or decrease, but the ratio must be maintained. If the amount of carbonate decreases, the pH decreases, causing a state of acidosis. The pH to be returned to normal if the amount of carbonic acid also decreases. This type of pH adjustment is referred to as compensation. Respiratory system compensates for change in the pH by increasing or decreasing the concentration of carbon dioxide by changing ventilation. The renal system compensates by producing more acidic or more alkaline urine. The correction occurs when the values of both components of the buffering pair return to normal levels. This is just showing you how that pH works. So acid-base imbalances. So normal arterial blood pH is 7.35 to 7.45, obtained by an arterial blood gas sampling. So acidosis is systemic increase in the hydrogen concentration or decrease in bicarbonate base. Alkalosis is systemic decrease in the hydrogen concentration or an increase in bicarbonate. Okay, acidosis and alkalosis. There's four categories of acid-base imbalances. There's respiratory acidosis, which is elevation of the PCO2 as a result of ventilation depression. There's respiratory alkalosis, depression of PCO2 as a result of alveolar hyperventilation, and there's metabolic acidosis, depression of the HCO3 or a increase in non-carbonic acids, and there's metabolic acidosis, elevation of the HCO3, usually caused by an excessive loss of metabolic acids. And we're going to talk about each of these individually, so there's not a lot more to see on this slide. So as we're talking about respiratory acidosis, this results from an increase in carbon dioxide levels from a respiratory origin. Its cause can be airway obstruction, PE, chest injuries, pneumothorax, sedation, pneumonia, atelectasis, any condition that depresses the respiratory system, COPD, head injury, CNS depression, impaired respiratory muscle function. The effects can be acidic urine, headache, behavioral changes, tremors, weakness, flushing. When you look at this, your blood gases are going to have a lower pH of 7.35. Your CO2 is going to be greater than 45. Your HCO3 is going to be normal or elevated if it's compensated. And symptoms may include lethargy, blurred vision, headache, tremors. Coma is possible. Hypertension, cardiac changes are possible. Cardiac conduction changes are possible. So you have respiratory alkalosis. This develops from a decrease in carbon dioxide level from a respiratory origin. Causes any condition that causes hyperventilation and subsequent hypocapnia, which produces an elevation of pH. Hyperventilation, high fever, anxiety, and aspirin overdose, tremors or head injuries, which impact the respiratory control center in the brain. Effects can be alkaline urine, dizziness, lightheadedness, tetany, seizures, cardiac arrhythmias, anorexia, nausea, lethargy, weakness, um, flushing, confusion, and then your blood gases are going to be a pH of greater than 7.45, a CO2 of less than 35. Your HCO3 is going to be normal or low for compensating. Metabolic acidosis results from a renal or metabolic problem that causes a decreased level of bicarbonate in the body. The ion gap can be assessed to determine if metabolic acidosis is caused by retention of chloride or loss of bicarbonate. The ion gap equals sodium minus chloride equals bicarbonate. An ion gap of less than 11 milliequivalents is considered normal. An increase in the ion gap usually is caused by an increase in unmeasured ions that most commonly occurs when there is an increase in unmeasured organic acids that is in acidosis. Causes increased levels of keto acids, lactic acid, excess loss of bicarb via the kidneys or GI tract, due to an increased serum chloride concentration. Renal failure, diarrhea, lactic acid accumulation, ketoacidosis and diabetes, hypoxemia, starvation. Effects could be weakness, lethargy, confusion, headaches, small respirations, can progress to coma and death. Your blood gases are going to be less than 7.35, CO2 normal or low, compensating, HCO3 less than 22. So metabolic alkalosis occurs from a loss of hydrogen ions through the kidneys or the GI system. Causes either an excess of base or a loss of acid within the body, can cause metabolic alkalosis, ingestion of antacids, excess use of bicarbonate, loss of acids through vomiting, gastric section, hypochloremia, excess administration of diuretics, a high level of aldosterone. Effects can be muscle twitching, tingling around the mouth, restlessness, hyperactive refluxes, decreased respiratory rate, seizures, tetany, and coma. Blood gases can be a pH greater than 7.45. Your CO2 is normal or elevated if compensating. HCO3 greater than 28. So from here on out, I've got everything on the slides because I think it's easier to see and to read. And it's how, when we're looking at ways to evaluate these acid-base imbalances. So first off, we're going to use an arterial blood gas. An arterial blood gas, or an ABG, tests and measures the levels of oxygen and carbon dioxide in the blood to determine how well your lungs are working, okay? Blood may be collected from one of following arteries: a radial artery in the wrist, femoral artery in the groin, or brachial artery in the arm. I can tell you, if you've ever had these done, it is not pleasant to have drawn. So when you do have these, they usually are put on ice and they need to go immediately to the lab. Do not let these specimens go to waste. They're not fun to get drawn and nobody enjoys it. and it's crucial they get taken right away. Um, so, what it measures is your partial pressure of oxygen, which is your PaO2. I have a W there, I'll fix that. 75 to 100 is mmHg, is what it should be. Your partial pressure of carbon dioxide, which is your PaCO2, which is 35 to 45. Your arterial blood pH, which should be 7.35 to 7.45. Your oxygen saturation, which is SaO2, which is 94 to 100%. Your bicarb, which is your HCO3, should be 22 to 28 milliequivalents per liter. So when you're trying to read these, first you must understand the key components of the blood gases. To determine an acid-base imbalance, you are evaluating the pH, the PCO2, and the HCO3. So your pH, that's measurement of acidity. Your pH greater than 7.45 is alkalosis. pH under 7.35 is acidosis. Your PCO2 is the amount of carbon dioxide in the blood. Your PCO2 greater than 45 is acidosis. Your PCO2 less than 35 is alkalosis. Your HCO3, the calculated value of the amount of bicarb in the blood, if it is your HCO3 greater than 28 is alkalosis. Your HCO3 under 22 is acidosis. So I borrowed this from Dr. Coulter on an easy way to remember this, and it's using Rome, ROME. So respiratory, O is the R, O is opposite. So you've got your alkalosis, pH goes up, PaCO2 goes down. For acidosis, your pH goes down, your PaCO2 goes up. And your metabolic and is for the M, and your equal. So then your acidosis, your pH goes down and your HCO3 goes down. For alkalosis, your pH goes up and your HCO3 goes up. So then it becomes a stepwise matching game. So step one, identify whether the pH, the PCO2, and the HCO3 are abnormal. For each component, label it as normal, acid, or alkaline. Step two, if the ABG's results are abnormal, determine if the abnormality is due to the kidneys, metabolic, or the lungs, respiratory. Step 3, match the two abnormalities, CO2 respiratory and HCO3 metabolic, with the abnormal pH. And step 4, label your acid-base imbalance. Then you have to decide if it's compensated or uncompensated. So when an imbalance exists over a period of time, the body will work to buffer or compensate. Reminder, the kidneys and the lungs are the primary buffering systems, so the body will try to overcome the imbalance and return the pH to a normal range. So uncompensated is when an acid-base disorder is either uncompensated or partially compensated. The pH remains outside the normal range. Compensated is when the pH has returned to within the normal range, although the other values may still be abnormal. If your pH is compensated, you will need to look at it in a different way to determine the imbalance. You will look to see if the pH is closer to 7.35 or to 7.45, then match your imbalances accordingly. You can have mixed acid-base imbalances, and these do not happen often. Your mixed acid base disorders occur when there has been more than one primary acid base disturbance present simultaneously. They are frequently seen in hospitalized patients, particularly in the critically ill. When to suspect a mixed acid base disorder is when you have a compensatory response occurs, but levels of compensation is inadequate or too extreme. Whenever the PCO2 and the HCO3 become abnormal in opposite directions, for example, one is elevated while the other is reduced. So, a rule of thumb is when the PCO2 is elevated and the PCO3 is reduced, respiratory acidosis and metabolic acidosis coexist. When the PCO2 is reduced and the HCO3 elevated, respiratory alkalosis and metabolic alkalosis coexist. So, examples of causes of this is salicylate intoxicity. It's been a long lecture. Intoxicity, gram-negative sepsis, acute cardiopulmonary arrest, or severe pulmonary edema. And we are officially done. Good luck. I do recommend doing the extra things with this because it helps solidify this, because this is a hard unit.